I want to tell you about a patient I will call George, 68 years old, retired engineer, disciplined about his health his entire life, annual checkups without fail for 30 years, cholesterol tested every year. Every year his doctor looked at the result and said the same thing: your cholesterol looks fine, keep doing what you are doing. 6 weeks after his last checkup, the one where his cholesterol looked fine, George had a heart attack, not a mild event, a significant heart attack that required emergency surgery and left permanent damage to his heart muscle. When I reviewed his records afterwards, something stood out immediately. His total cholesterol number was indeed acceptable. His LDL, his so-called bad cholesterol, was borderline but not dramatically elevated. His doctor had looked at those numbers and seen nothing alarming. But there was a number hiding inside that same blood test that nobody had looked at, a number that had been quietly screaming for 3 years. That number was his LDL particle count. And today I am going to explain what it is, why it matters more than the cholesterol number your doctor discusses with you, and how to find out what yours is before it tells its story the way George's did. Stay until the end. Because the last thing I share today is a conversation you need to have at your very next appointment. Word for word, I will give you exactly what to say. First, let me explain what your standard cholesterol test is actually measuring. When your doctor orders a lipid panel, the standard cholesterol blood test, it measures 4 things: total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. These 4 numbers have been the foundation of cardiovascular risk assessment for decades, and they are genuinely useful. They tell you something real and important, but here is what they do not tell you. They measure the amount of cholesterol carried in your blood. They do not measure the number of vehicles carrying it. And the vehicles, the particles, matter more than the cargo. Let me explain this with a simple picture. Imagine a highway. The highway is your bloodstream. The vehicles on the highway are LDL particles, tiny spheres that carry cholesterol through the blood. Now imagine 2 people. Person A has 100 large trucks on their highway. Each truck is carrying a large load of cholesterol. Person B has 300 small cars on their highway. Each car is carrying a small load of cholesterol. Both people may have the same total amount of cholesterol on the highway. The standard cholesterol test may show identical numbers for both, but person B has 3 times as many vehicles, 3 times as many particles that can bump into the walls of the arteries, 3 times as many opportunities for a particle to get lodged in an arterial wall and begin the process that leads to a plaque, that leads to a blockage, that leads to a heart attack. This is LDL particle number, or LDLP, or in a related test, apolipoprotein B, ApoB. And research over the past 2 decades has consistently shown that LDL particle number predicts cardiovascular risk more accurately than LDL cholesterol level alone. More accurately, not slightly more accurately, significantly more accurately. Here is where it gets important for you personally. There is a specific pattern, extremely common in people over 60, in people with diabetes, in people with metabolic syndrome, in people who carry weight around the abdomen, where the standard LDL number looks acceptable or even good, but the LDL particle number is dangerously elevated. This person goes to their annual checkup. The doctor looks at their LDL. It is not alarming. No action is taken, but inside their arteries, hundreds of small, dense LDL particles are quietly embedding themselves in the arterial walls, building plaque, narrowing the vessels. For years, silently, this was George's situation. His LDL cholesterol number was borderline. His LDL particle number, never tested, never discussed, was extremely elevated. He had what cardiologists call discordance. The standard number and the particle number told completely different stories, and the standard number was the only one anyone looked at. The small, dense LDL problem. Not all LDL particles are the same size. Large, buoyant LDL particles are less dangerous. They are less likely to penetrate the arterial wall. Small, dense LDL particles are significantly more dangerous. They are small enough to penetrate the arterial wall more easily. They oxidize more readily, meaning they become the type of cholesterol that triggers the inflammatory process that builds plaque, and they stay in circulation longer because the body's receptors are less efficient at clearing them. A person can have a moderate LDL cholesterol level but have the majority of their LDL in the small, dense form, and their cardiovascular risk is dramatically higher than their standard test suggests. Standard cholesterol tests do not distinguish between large, buoyant, and small, dense LDL. They measure the total cholesterol cargo, not the particle type, not the particle size, not the particle number. What raises small, dense LDL and particle number? High triglycerides. This is the single strongest association. When triglycerides are elevated, above 150, The liver produces more small dense LDL particles. Triglycerides and particle size are directly linked. Insulin resistance and diabetes. Elevated blood sugar drives the production of small dense LDL and increases overall particle number. Abdominal obesity. The specific pattern of weight carried around the waist, visceral fat, is directly associated with small dense LDL production. Sedentary lifestyle. Regular aerobic exercise shifts LDL from small dense to large buoyant. Inactivity does the opposite. Refined carbohydrates and sugar in the diet. These raise triglycerides and shift LDL toward the dangerous small dense form more powerfully than dietary fat in most people. If you have any of these factors, and many seniors have several, your standard LDL number may be significantly underrepresenting your true cardiovascular risk. Let me tell you about the tests that actually reveal this. Test 1. ApoB, apolipoprotein B. Every LDL particle has exactly one ApoB protein on its surface. One particle, one ApoB molecule, without exception. This means measuring ApoB directly counts the number of LDL particles. High ApoB means many LDL particles regardless of what the standard cholesterol number shows. It is the most direct available measurement of LDL particle burden. An optimal ApoB level is below 80 mg per deciliter for most people. For those with diabetes or established heart disease, below 70 is the target many cardiologists now use. ApoB is increasingly available on standard blood panels. In many places it costs the same as or very little more than a standard lipid panel, and it tells you something your standard cholesterol result simply does not. Test 2. NMR lipoprofile or advanced lipid panel. This specialized test directly measures LDL particle number and LDL particle size. It gives you the count of particles and tells you whether they skew toward large buoyant or small dense. This test is not universally available and may have some additional cost, but for someone with risk factors, diabetes, high triglycerides, abdominal obesity, family history of early heart disease, it provides information that can genuinely change the clinical picture and the treatment approach. Test 3. Lipoprotein A, written LPA. This is a separate cholesterol particle entirely, genetically determined, not meaningfully affected by diet or lifestyle, and significantly elevated in approximately 20% of the population. Elevated LPA is an independent risk factor for heart attack and stroke. It is not tested in standard lipid panels. Most people have never had it measured, and because it is genetic, it is present from birth, waiting silently until the arterial damage accumulates to a critical point. It needs to be measured once. If it is normal for life. If it is elevated, it changes the entire cardiovascular risk calculation and the treatment strategy. LPA. Testing is simple, a single blood draw. Ask for it by name at your next appointment. The triglyceride to HDL ratio. There is one calculation you can do yourself right now from your most recent cholesterol results that gives a rough indication of whether you may have the small dense LDL pattern. Find your triglyceride number, find your HDL number, divide triglycerides by HDL. A ratio below 2 suggests you predominantly have large buoyant LDL. Lower risk pattern. A ratio between 2 and 3 is intermediate. A ratio above 3 suggests you likely have predominantly small dense LDL. Higher risk pattern regardless of what your LDL number shows. A ratio above 4 is significantly associated with insulin resistance and small dense LDL dominance. If your ratio is above 3, this is a specific conversation worth having with your doctor. What to do with all of this? Step 1. Find your most recent cholesterol results. Calculate your triglyceride to HDL ratio. Write it down. Step 2. At your very next doctor appointment, say these words exactly. I would like to discuss my LDL particle risk. I want to ask about testing my ApoB level and my LPA. Can we add these to my next blood panel? That is it. Those words, ApoB, LPA. Write them on your phone before the appointment so you do not forget. A doctor who takes cardiovascular risk seriously will engage with this question directly. They may already be tracking these numbers. If they dismiss the question entirely, that itself is information worth acting on. Step 3. Address the lifestyle factors that drive small dense LDL regardless of what your results show. Reduce refined carbohydrates and sugar, not because of dietary fat, because sugar and refined carbohydrates raise triglycerides and drive small dense LDL production more powerfully than almost any other dietary factor. Move every day. Even 20 minutes of walking shifts LDL particle distribution toward the safer large buoyant form over time. Control blood sugar if you are diabetic or pre-diabetic. Every improvement in blood sugar control improves the LDL particle picture. Step 4. If you are already on a statin, ask your doctor specifically whether your statin is being dosed to an LDL target or to an ApoB or particle target. Statins reduce LDL cholesterol very effectively. Their effect on LDL particle number is somewhat less consistent, particularly in people with the small dense LDL pattern. Some people on statins achieve a good LDL number but still have an elevated particle burden. Knowing which target your treatment is aimed at and whether it is being achieved is a legitimate and important question. Let me tell you what happened to George after his heart attack. When we reviewed his case and tested his ApoB and particle number, the results were clear. His LDL particle count had been dangerously elevated for years. His standard LDL number had been moderately elevated but not alarming. The discordance between the two numbers was significant. His treatment was adjusted. His dietary pattern was changed with specific focus on reducing refined carbohydrates and improving his triglyceride to HDL ratio. His medication was optimized with an ApoB target rather than an LDL target. 12 months later, his ApoB was well within the optimal range. His particle count had dropped dramatically. He told me at his last visit that he wished someone had explained this to him 10 years ago, that a number nobody ever mentioned had been building toward the event that changed his life. Now you know what that number is. Now you know what to ask for. Your action steps from today. 1. Calculate your triglyceride to HDL ratio from your most recent results. 2. Ask your doctor for ApoB and LPA testing at your next appointment. Say those words by name. 3. If your triglyceride to HDL ratio is above 3, treat this as a priority conversation, not a routine one. 4. Share this video with someone who monitors their cholesterol and assumes that because the number looks acceptable, they are protected. They may not be, and now they have the information to find out. Subscribe for new videos every week. Information your appointment does not have time to deliver. I will see you in the next one.